Question 95. A woman arrives with symptoms of pruritus and jaundice. Her lab results reveal elevated liver function tests, bilirubin levels, alkaline phosphatase, and a positive antinuclear antibody test. A liver biopsy shows evidence of plasma interface hepatitis. Which treatment option is most appropriate in this case? Option A, prednisolone. Option B, methotrexate. Option C, ursodeoxycholic acid. The most suitable treatment option is option A, prednisolone. Explanation. The clinical presentation is indicative of autoimmune hepatitis. The treatment of choice for autoimmune hepatitis involves immunosuppressive therapy to suppress the immune system's attack on the liver. Prednisolone, a corticosteroid, is a common and effective treatment in such cases. The other options are not the primary treatment approach for autoimmune hepatitis. Methotrexate might actually exacerbate liver inflammation in this context. Ursodeoxycholic acid is commonly used to treat certain types of liver conditions, such as primary biliary cholangitis, but it is not the primary treatment for autoimmune hepatitis. Question 96. A child presents with a painful, reddened, and swollen half of the scrotum. During examination, a mass is felt with no increase in size during coughing. The mass is tender and extends into the inguinal area. The left testicle cannot be felt. Which of the following options is the most probable diagnosis? Option A, testicular torsion. Option B, epididymal orchitis. Option C, incarcerated inguinal hernia. Option D, testicular appendicular torsion. The most likely diagnosis in this scenario is option C, incarcerated inguinal hernia. Here's a breakdown of the key features supporting this diagnosis. Painful and swollen hemiscrotum. Negative cough impulse. Tenderness and extension to inguinal area. Left testicle is not palpable. These are the major contributing signs and symptoms to reach the diagnosis. Question 97. A patient with celiac disease who is not adhering to a gluten-free diet and is currently taking oral iron once daily has presented with symptoms of pallor and fatigue, and their hemoglobin level is low at 9.7 gram per deciliter. What is the most suitable course of action? Option A, increase the frequency of oral iron tablets to 3 times a day. Option B, switch to liquid oral iron. Option C, consider intravenous iron therapy. Option D, maintain the current treatment approach. The most appropriate course of action in this situation is option C, consider intravenous iron therapy. Here's an explanation. Celiac disease can lead to malabsorption of essential nutrients, including iron, due to damage to the lining of the small intestine. If a patient with celiac disease is not compliant with a gluten-free diet, this malabsorption can persist, making it difficult for them to adequately absorb oral iron supplements. The patient's low hemoglobin level of 9.7 gram per deciliter indicates that their iron deficiency anemia is not adequately responding to the current treatment with oral iron once daily. Intravenous iron therapy can be a more effective and efficient way to replenish iron stores in cases where oral iron is not well absorbed or tolerated. Intravenous iron bypasses the digestive system and delivers iron directly into the bloodstream, ensuring that the body receives the iron it needs. It is particularly beneficial when oral iron supplements are ineffective due to malabsorption, noncompliance, or gastrointestinal side effects. Question 98. A patient with a history of COPD, who is alert and experiencing moderate respiratory distress, has a blood oxygen saturation of 93%. An arterial blood gas analysis has revealed hypoxia, hypercapnia, and acidosis. What should be the next course of action? Option A, initiate non-invasive ventilation. Option B, reduce the oxygen flow. Option C, increase the oxygen flow. Option D, consider mechanical ventilation. The most appropriate next step is option A, initiate non-invasive ventilation. Here's an explanation. Patients with a history of COPD are at risk of acute exacerbations, especially when they develop respiratory distress. In this case, the patient is experiencing moderate respiratory distress, which can be a sign of an exacerbation. The ABG analysis has shown hypoxia, hypercapnia, and acidosis. These findings suggest that the patient's respiratory distress is causing inadequate oxygenation and ventilation. Non-invasive ventilation such as BiPAP or CPAP can be highly effective in managing respiratory distress in COPD patients. It helps improve oxygenation and ventilation without the need for invasive procedures like intubation and mechanical ventilation. Increasing oxygen flow might further worsen the hypercapnia and acidosis in some COPD patients. It's essential to be cautious with oxygen administration in COPD patients. Reducing oxygen flow could also be detrimental if the patient's oxygenation is already compromised. While mechanical ventilation may be necessary in severe cases, non-invasive ventilation is often the first step in managing acute respiratory distress in COPD patients. Question 99. A patient is reporting dizziness upon waking up, experiencing sensations of warmth and flushing, watery diarrhea, and itching. During examination, the abdominal assessment appears normal, while the respiratory examination reveals wheezing. There may be a cardiac murmur present, but it's uncertain. What diagnostic test would you consider ordering? Option A, measurement of amylase and lipase levels. Option B, abdominal and pelvic ultrasound. Option C, urine analysis for 5-hydroxyindole acetic acid. Given the patient's symptoms and clinical findings, the most appropriate diagnostic test to order would be urine analysis for 5-hydroxyindole acetic acid. Explanation. The patient is presenting with dizziness, warmth and flushing, watery diarrhea, itching, and wheezing. These symptoms, along with the possibility of a cardiac murmur, suggest a potential issue related to hormonal or neuroendocrine function rather than a typical abdominal or respiratory problem. Measurement of 5-hydroxyindole acetic acid in urine is a diagnostic test used to assess the levels of serotonin metabolites. Elevated 5-hydroxyindole acetic acid levels are associated with carcinoid syndrome, a rare neuroendocrine tumor that can cause flushing, diarrhea, and wheezing due to the excessive release of serotonin and other bioactive substances. Other options: exclusion. Amylase and lipase levels are typically ordered to evaluate pancreatic function and would not be the primary diagnostic test in this case, as the patient's symptoms are not suggestive of acute pancreatitis. An abdominal and pelvic ultrasound may be considered if there were abdominal symptoms or findings suggesting a gastrointestinal issue. Question 100. A patient has been discovered to have an elevated renal profile and hematuria. There is a family history of several family members experiencing renal failure requiring hemodialysis. Upon examination, the patient also exhibits bilateral hearing loss. What is the most probable diagnosis among the following options? Option A, granulomatosis with polyangiitis. Option B, eosinophilic granulomatosis with polyangiitis. Option C, Alport syndrome. Option D, immunoglobulin A nephropathy. The most likely diagnosis is option C, Alport syndrome. Here's an explanation. Alport syndrome is a genetic kidney disorder that often presents with hematuria as one of the initial symptoms. It can progress to kidney dysfunction, leading to an elevated renal profile. Alport syndrome is hereditary and can run in families. The presence of multiple family members with renal failure requiring hemodialysis is suggestive of a genetic kidney disease like Alport syndrome. Bilateral hearing loss is a feature of Alport syndrome and can help distinguish Alport syndrome from other kidney diseases. Option A and Option B are autoimmune disorders that can involve the kidneys but are usually associated with other systemic symptoms such as respiratory and skin manifestations. Option D, immunoglobulin A nephropathy, is a kidney disease characterized by the accumulation of immunoglobulin A in the kidneys. While it can cause hematuria, it does not explain bilateral hearing loss or a strong family history of renal failure.